Hi everybody, good morning. So today we will discuss about urinary tract infection management and few points on the 2023 Indian Society for Pediatric Nephrology updates on UTI and VUR. See, urinary tract infection is a very common infection. Around 2% of boys and around 8% of girls before the age of 7 tend to have this. Okay. And major risk factors for any child having a urinary tract infection would be a VUR, vesico-ureteric reflux. BBD is bowel and bladder dysfunction. Okay. So, what are the organisms that you need to be aware of? As far as a urinary tract infection is concerned, the most common organism would be a E. coli. Understood? So, that's the most common organism that you will see. The other organisms would be Klebsiella, Proteus, Enterococcus, Pseudomonas. But if you have an ultrasound report that says there is an evolving abscess that is sitting there, Staphylococcus will also come into the mix. So, how do you identify, how do you suspect that somebody is having a urinary tract infection? So, it is like this. In a neonate, generally neonatal infections, they don't present with fever. They present more with failure to thrive, poor feeding, irritability, jaundice, and all that. Okay. In a young infant, a child who's coming with fever without focus, always suspect UTI. Okay. And this child may or may not have like urinary symptoms specifically, where the mother is telling a change in color of urine, change in smell of urine. I mean, if you have something like that, you're lucky, but many a times that may not be there. And when such a child comes, as part of your examination for fever without focus, always examine the perineal region. For example, in a female child, if you're having lot of synechia in the vaginal region, high chances that the child could be having a urinary tract infection. A male child, you're pressing the penile region and you're seeing pus is coming out, or you're seeing that there is a phimosis that is sitting there in a male child. Yeah, those are all risk factors. So this could be UTI. Okay, when you want to tell UTI, it needs to be confirmed microbiologically. I'm not telling no, but these are all the situations when you will suspect that there is a urinary tract infection as a focus of fever for this patient. Older children will come with classical symptoms like I am having fever, there is burning micturition, there is urgency, there is dysuria. All of those symptoms can be there. If it is going up till the kidneys, then you can have toxic symptoms, patient being dull, you can have renal angle tenderness. So those are the classical symptoms that you would expect, but that's more in older age group. Again, depending upon what is the localization of the UTI. Say if it is cystitis, more of lower urinary tract symptoms of frequency, dysuria, urgency, all of those things will come. If it is pyelonephritis, then high grade fevers, toxic look, renal angle tenderness, all of those symptoms can be present and signs can be present. Now, how does a UTI come? Where does it come from? Most of the times, it is ascending infection. Ascending infection naka, where is it from? So usually the fecal flora, when a parent is cleaning up the child after the child has passed motion, and the way in which they clean, if the fecal particles are going to come to the front, say vaginal region or a penile region, then yes, so it's very common to have a ascending infection from down to up. Okay. Suppose the preputial region in a male child is not clean, and that can become the focus for bacteria to ascend up. Sometimes a cystitis can ascend up into kidney to become a pyelonephritis. In a young child, especially neonate, generally UTI rather than ascending infection, it's a hematogenous spread. Rarely it can spread from local areas. Say, for example, there is a vertebral osteomyelitis or there is a psoas abscess that is sitting there. So, from there, urinary tract infection can happen. Reflux, especially high grade reflux, grades 3 to 5, become risk factors for urinary tract infection, and so does bowel bladder dysfunction. Okay. Normally, kidney has mechanisms where you do not have intrarenal reflux. like your bigger pyramids have mechanisms where it does not allow reflux of the urine into collecting tubules. This is a normal protective mechanism, but few in the upper and lower pole of kidney do allow intrarenal reflux. That is why if you have a localized infection, you can generally see ultrasound report saying it's in the upper pole of kidney or in the lower pole of kidney, or if you're having a scarring later on, it generally says upper pole of kidney or lower pole of kidney. Okay, so now you know when to suspect, why it is happening, what are the common organisms. Now how do you diagnose? You have suspected, correct? So what are the investigations you will send? The first investigation that you will send will obviously be urine, because that is where you want to know whether the infection is there or not, correct? So how do you send the urine? So in a toilet trained child, clean catch is good enough. Okay, even in young children, now slowly we are moving towards something called as quick wee method, where in an infant after breastfeeding, cold sponging in the lower part of abdomen will make them pee, and then you can do a clean catch. Clean catch is where the initial part of urine is left out, because that's generally contaminated with whatever is there in the periurethral region, and a midstream catch is done. But in a sick infant, say less than 2 month old, who is having multi-organ failure and you feel it's more of urosepsis, in those children, you do either a catheterization, or if catheterization is not possible, suprapubic aspiration to send for urine routine and culture sensitivity. Okay, do not put uro bag on a patient to collect. So small, those minicom collection bags, please do not do. It is generally contaminated, and if at all you catch that and there is nothing that is growing there, then that can be taken as significant. Okay, it's got a very good negative predictive value, but don't do that, because you are not going to get useful information there. Okay, at the most what you will get, illa there is no bacteria in the urine, correct? Only that much you can do. But if there is bacteria, then now you don't know whether it is a true pathogen or it's a contaminant. So never do it from a collection bag. What if the patient is already having a urinary catheter in place? Don't collect from the bag that is hanging on the patient. Collect from the catheter that is there in the patient. Okay, because whatever is there in the bag will be growing all sorts of organisms. So you can't take from the bag, always take from the catheter. Okay, okay, so this is how you collect, and the test that you send for would be routine examination and culture. Routine, what are the things you will look for? Microscopy, you will see, is there a WBC, is there a bacteria that is sitting there. Okay, uncentrifuged urine, if you are seeing bacteria, it is significant. As far as WBC is concerned, anything more than 5 WBC in one high power field in a centrifuged sample, or more than 10 in an uncentrifuged sample is considered significant. Note that there can be something called a sterile pyuria. Sterile pyuria means you are seeing just WBCs in the urine, and this can be secondary to any sort of inflammation. It need not be just urinary tract infection. UTI is just one of the reasons why your urinary tract is inflamed. Correct? In Kawasaki, there can be sterile pyuria. Correct? So that's just one example. So similarly, multiple inflammatory diseases can cause just sterile pyuria without seeing any bacteria in it. All right. The other investigation that you do for a routine examination is leukocyte esterase and nitrite. Leukocyte esterase, if there is a leukocyturia, you can have leukocyte esterase being positive. But for nitrite, you need to have these nitrate reducing bacteria. But there are a few caveats here. For this nitrate to get reduced to nitrite, the bacteria should be capable of doing it, correct? Certain bacteria like Enterococcus will not be able to do it. Second thing, even if the bacteria is capable of doing it, it needs some time. Alright. So, in any child who is frequently voiding, then there is no time for the urine to stay in the bladder for the nitrate to get converted to nitrate. So, you will not see it at all. So, young infants who is frequently voiding, your nitrite can remain negative despite child having a urinary tract infection. Okay. So, if I am not clear, I will just repeat it once again. For bacteria to convert this nitrate to nitrite, the urine needs to stay for at least 3 hours. Okay. If in a young infant, every 1 hour, 2 hours, child will continue to pass urine. So there is no time for this conversion to happen. So it can remain negative despite child having a urinary tract infection. So routine la WBC you will see, bacteria you will see, leukocyte esterase you will see, nitrate you will see as a dipstick test. Okay, va? Culture la you need to have a single colony which is growing. Single colony in solatuma? No. Single bacteria which is growing. Okay, if there are multiple organisms that are sitting there, mostly it represents contamination. So when you have a single organism growing, suprapubic culture anything more than or equal to 10 power 3 is significant. Catheter sample more than or equal to 10 power 4. In a clean catch more than or equal to 10 power 5. All of this is in the context of the clinical information that you have. Okay, so isolated or don't try to diagnose things. And once you have collected for culture, ensure that it is processed immediately. Suppose it looks like it is going to take some time, then it needs to be stored in a refrigerator at 2 to 8 degrees Celsius. Why do you need to do that? If you keep it in room temperature, the other colonizing bacteria will proliferate more and more. All right, so that is why you keep it in fridge. As a thumb rule, any how to tell, any sample which is contaminated needs to be processed immediately, and if not processed, it needs to be stored in fridge. Any sterile sample, say CSF length you are taking or from blood you are taking, you don't have to put it in fridge. Even if it is at room temperature, processed say a few hours later, it is still okay. All right, so this is about diagnosis. Now that you have diagnosed, how do you treat? You need to start treating empirically, especially if you think UTI is the focus. Generally, third generation cephalosporin or amoxiclav can be used. Compared to amoxiclav, cephalosporins are better. Oral cefixime is preferred. Okay, va? So, if it is a young infant, significantly ill, you feel it is a pyelonephritis that is sitting there, because apart from urine, you will send samples like your CBC, CRP, you are seeing CRP is way elevated than before, or you have done an ultrasound and it is showing pyelonephritis, then IV antibiotic would be preferred. Non-complicated UTI, yeah, your oral medication will do, but please don't give nitrofurantoin. Why no nitrofurantoin? Because nitrofurantoin is a drug that is good for bladder level UTI, okay, not for kidney level, because the drug does not get concentrated in this upper urinary tract. So if you are suspecting upper urinary tract infection, say a degree like a pyelonephritis, then nitrofurantoin is definitely not the drug of choice. All right. How long do you give once you have started treatment? Febrile UTI, 7 to 10 days is more than enough. 3 to 7 days if it is going to be cystitis. Asymptomatic bacteriuria, you do not have to treat, and you wait for 48 to 72 hours. See if the symptomatology is improving. If symptomatology is not improving, then you can send a repeat culture and change antibiotics. Otherwise, if the child is improving, continue the same antibiotic. Why? Even if your culture sensitivity comes little bit ulta pulta, you have started say ceftriaxone, child has clinically improved, your report is showing no, this is a ESBL organism. But if child is clinically improving, that is more important, because there are a lot of in vivo and in vitro sensitivity changes. Okay, so your paper might show that it is resistant, but clinically child is improving, then complete the course of antibiotic. No need for repeat urine cultures if the child is improving. Okay. So, how do you image this patient? All UTI, please do an ultrasound. Please get an ultrasound. Okay. So, once you get an ultrasound, then what do you need to do? So, we will go through this framework that is given in the ISBN 2023 update. So, you have suspected UTI, you have sent dipstick and culture, and urine culture is positive, you have confirmed the UTI. Paravalla. You will assess for bowel bladder dysfunction. Okay, va? So once you assess for bowel bladder dysfunction, try to manage that. You have done an ultrasound. If ultrasound is abnormal, then you complete the course of antibiotics. Wait for up to 2 to 3 weeks as per convenience of both parent and the patient, and then you do a MCU, micturating cystourethrogram. Basically, you want to look to see if there is a reflux that is sitting there or not. Why do you want to see? If it is a high grade reflux, then you might have to start on antibiotic prophylaxis. That is why you do the MCU study. Or if the patient is having a recurrent UTI, again you go ahead and do a how to tell the next step of investigation, which would be a late phase DMSA scan. DMSA you basically look for morphological changes, M and M. You want to look for renal scarring that is sitting there. Okay. MCU can also be considered if the UTI is secondary to a non-E. coli pathogen. Okay, then also you go ahead and do a MCU study, because it's not very common to have a non-E. coli UTI. Most of the cases turn out to be Escherichia coli induced urinary tract infection. Okay. So, MCU you will do if there is a recurrent UTI, non-E. coli UTI, or an abnormal ultrasound in the first sitting. You will do your late phase of DMSA only if it is a recurrent UTI or high grade VUR, high grade VUR being grade 3 to grade 5. Okay. So, once you have done these three investigation, find out what the reports are. Okay. Why do you need to know? You need to know if you have to start on antibiotic prophylaxis. So, you will start for 3 to 5 VUR, or there is a bowel bladder dysfunction. You have managed the bowel bladder dysfunction appropriately, but still child is going ahead and having a recurrent UTI, correct? Then you start an antibiotic prophylaxis. More than 3 months, you can do it with cotrimoxazole or nitrofurantoin. Less than 3 months, you can do with cephalexin. You can discontinue if the patient is toilet trained, there is no bowel bladder dysfunction, and last 12 months child has not had an episode of UTI. You need to avoid broad spectrum antibiotic for prophylaxis. What are all the other things that you will do? Cranberry products, see, it's effective in recurrent UTI with a normal tract, but there are not many studies to tell you take only this, nothing else is required. Okay. Circumcision can help for boys who are having recurrent UTI with high grade VUR, and lot of behavioral therapy for bowel bladder dysfunction, helping them with the food, water, the position in which they defecate, and follow up for bowel bladder dysfunction is extremely important. And when you have a vesicoureteric reflux, antibiotic prophylaxis and bowel bladder treatment will be the primary thing. Surgery will be considered if there is a recurrent febrile UTI, despite you taking care of rest of the things. Endoscopic bulking can be tried for VUR. It's minimally invasive. That's the advantage, but it is less effective than actual ureteric reimplantation. And the long term follow up, of course, needs to be done for any primary VUR to see if they are going to be evolving chronic kidney disease. So, if you have a child, febrile child, no focus, suspect UTI, you will need to send for urine routine examination and culture. We saw what things are needed. You will start on antibiotics empirically, and you don't have to repeat cultures if the child is improving. Not improving after 48 hours, you will do. Investigation wise, radiologically, you will do ultrasound first for all UTI, and only in certain situations you will go ahead and do MCU and your late phase DMSA. Key risk factors that need to be managed will be your VUR and your bowel bladder dysfunction. Okay, that's it about urinary tract infection. If you have any questions, put it down in the chat box. I will get back to you as early as possible. Thank you and all the best.